So, ladies and gentlemen, I have got a very important guest with me, Dr. Prateek Sharma, who is one of the brightest gastroenterologists in US of Indian origin. And Prateek happens to be a professor of medicine at the University of Kansas. And he also has risen in the hierarchy of various US societies. He is the president of International Society of Disease of Esophagus, ISDE, and he is also the treasurer-elect of American Society of GI Endoscopy. So he is a very active gastroenterologist. He is a very eminent academician, and more than that, he is a very humble and good person. So welcome, Prateek, to this meeting.
Thank you.
So Prateek, what I always wondered about you is that you have moved from India to US. So what made you take the decision, and tell us about your journey so that the youngsters listening to you can make decisions about their life.
Right. So thank you for those kind words. And for me personally, it's always a pleasure to be in India, and I try to come as frequently as I can, and it's coming home. Initially when I moved, really there was no plan for the move, and it just things happen in different ways. And my parents are physicians, doctors, and my brother was 2 years ahead of me in medical school, and he had just finished, and I was finishing medical college, and then there was a strike for 6 months, so I had nothing to do. So my brother said, why don't you start reading some books on this ECFMG, USMLE and stuff during that time period. So I had all plans after medical college to do the residency there. So I started reading, and I could get a free visit from my parents to Singapore to take the test, because at that time it wasn't done. So I said, okay, let's go and visit Singapore. I went there and I passed. I didn't realize that I had passed. I didn't think I would pass because I hadn't put in much work. And so it started indirectly like that. Right. But once I went there and I saw the system, I think it was it is geared more towards academics, or at least it gives you the opportunity to do that. And both during my residency, I was in Milwaukee at the Medical College of Wisconsin. Dr. Walt Hogan, one of the very eminent academicians in esophageal diseases, was there. Then I did my fellowship in gastroenterology at the University of Arizona, and Dick Sampliner, who's one of the gods of Barrett's esophagus, he was working there. So I was also very fortunate and lucky to have excellent role models and mentors.
Right.
So you always hear about that, and people say, but I think they make a huge difference.
Right.
And so I was just fortunate that I was at the right place at the right time. And then started my work in esophageal diseases because of that, and then just moved forward with it. So it just one thing led to another, and I saw them work hard. I saw them doing these clinical research projects. They taught me one thing which I think is very important, which is always ask very simple questions, right? I think we take a number of things for granted, like why does the LES or the lower esophageal sphincter relax? When you swallow, why does it relax? Because the food hasn't even reached there, right? So simple questions they asked, so then I also started following in their footsteps and started doing that. And ever since that I've continued, and the journey has been difficult. Again, I mean, as they say, one thing I've learned, that truly there are no shortcuts.
Right.
Again, not to boast any numbers or things like that, but now I have close to 400 publications, right? So one thing also you learn is that's something that nobody can ever take away from you.
That's right.
You do it, you've done the work, and so my message is that you have to put in your time, you have to put in the effort, and you have to recognize the US for what it is, that if you do that, your work gets recognized, people know who you are, and irrespective of where you are from, If the quality of the work is good, then you're as good as the others.
So that's interesting, because you did not plan to be there, but once you were there, you utilized the opportunity to the fullest.
Right.
And yes, that explains your exposure in Wisconsin and later on Arizona, why you became a the esophagus man. And today, in fact, I was amazed at every guideline has Prateek Sharma in it, and every guideline for GERD, for Barrett's, for motility, you have Prateek Sharma's footprints in that. So that tells me that you try to be very objective and put simple things in a very formatted manner, so that people can understand and have a uniform the understanding of the subject, rather than have their own views and own terminologies for this. Like the classification of Los Angeles classification of GERD, which you have contributed a lot, which has become a standard of reporting now with all of us. So what is it something ingrained that you try to do, that you make more the LA classifications? You always tend to objectivize things.
Yes, so I think I've always been a fan of simplicity. So if you follow the motto that keep it simple, right? I mean, I think that to me is important. So you will see these complex classification charts, you will see the flow chart and it's all over the place, and at the end nobody remembers anything.
Right.
And the same thing for lectures, for example, they always say that at the end of a 20-minute lecture, the human brain can only remember 3 things. So, so your message should be simple. So I'm a very, big fan of simplicity. So one of the things that I've tried to do over time is get people together and try to approach different diseases, whether it's an endoscopic classification system, whether it's a guideline, whether it's terminology, and how can you keep it in such a simple way, because one, remember it myself, contributing to it, but then also people who read it and people who follow it will also use it and will remember it. Because if you have something which is very complex and difficult and you cannot apply it for clinical practice, it may be a great publication, it may be in a very high impact journal, but I feel that I have not contributed. Because it is one additional publication in the field, but you're not having any impact clinically. So I feel that you ask a simple question which is clinically relevant, and if people can apply it in practice, I feel that that's when I've contributed to the science.
I agree, and that's why I think that most of those are becoming very popular and people relate to it. The other thing is that, Prateek, we always had this tug of war between endotherapy of GERD, and where do you think we are in this? Because we were one of the participants in initial development of endoscopic treatment for GERD, and then this all went through that. I remember Nagi Reddy giving a lecture on graveyard of endoscopic therapies, and the GERD therapy, he showed a tombstone on that. And it seems that we are trying to resurrect that. So where are we today?
So I think it's one of those things which comes in waves. And you're right. I mean, I think there was a time period about 10 years ago that it was at the peak, and then there was almost a downfall of it. And now I think you're right, it's coming back, at least in a limited way. And I think partly is that it's like a stock boom, right? If it's IT or it's power or financial, everybody buys into it, and then you say that, okay, it's going down, right? Because there's too much stuff. So part of the thing, what happened was that there were too many devices being tested, probably not vigorously tested. Side effects started happening, and you realize that it's a disease which can be reasonably well managed with medical therapy. So on one extreme you have medical therapy, on the other side you have surgical therapy. And I think endoscopic therapy is somewhere in between. So there definitely is a role. The reason for the tombstone or the graveyard you're discussing is because I think maybe we went too fast and we tried too many things in a rush to get there. And again, the same thing always happens. Whenever you try to rush towards something, things may not go right, and I think that's probably what happened with the GERD therapy. So now I think we've learned from our mistakes. and now we are taking a more cautious approach to it. We've learned from the previous technology. We are developing devices which are doing as good a job as fundoplication, so almost like an endoscopic fundoplication. Our patient selection is more appropriate. We are not trying to apply it to everybody with reflux disease. So that's why I feel that when you do that, you may have longevity there. And I do feel that GERD devices will work. It will be for a certain subset of the population. And as long as we apply it to the right population, it definitely will have a role.
Okay, Prateek, and you tell me, if you have to give 3 messages to the Indian gastroenterologist, so what are those which you will give?
So in general, I mean, I think I would say is, give it your best, which, again, it sounds like an old story, but I think it's true, is whatever you're doing, you should be interested in it. It should motivate you. Number 2 is keep it simple, ask whether you are in clinical practice. Now, doesn't mean everybody needs to write papers or write grants, but even if you're in clinical practice, keep it simple. Follow simple things, simple classification systems, simple algorithms that you can apply in practice. And number 3 is, try to keep up with the literature, and don't just blindly apply things that you have heard. Try to, go back to the fundamentals, see what is it that is either missing. And, again, meetings like this are a wonderful opportunity for young gastroenterologists to see what's the latest, greatest. And then also figure out, not just hearing you and me say that this is it and just start following it, but take that message home, see whether it works for them, and then start applying it to their patients.
So thank you, Prateek. We had wonderful talk, and dear friends, if you want to be another Prateek Sharma, then follow his advice. I think we had wonderful chat with him, and wish you, all the best.
Thank you, Randhir.